Good evening, everyone. Today, this is male genital tract pathology lecture. We will be discussing diseases of the prostate, bladder, and ureters. The prostate gland normally has three zones: the peripheral zone, the central zone, and the transitional zone. This distinction is important because different diseases affect different zones of the prostate. For example, cancer typically affects the peripheral zone, while benign prostatic hyperplasia affects the inner transitional zone. At the clinical level, this means that benign prostatic hyperplasia is more likely to present with urethral obstruction and urinary symptoms because it's directly related to the urethra, while the peripheral zone, which is affected by cancer, is less likely to present with these symptoms. On the other hand, since the cancer affects the peripheral zone, it's more likely to be detected by digital rectal examination. Prostatitis, which is inflammation of the prostate gland, can be divided into three subcategories: acute bacterial prostatitis, chronic bacterial prostatitis, and chronic pelvic pain, or chronic non-bacterial prostatitis. The diagnosis of prostatic inflammation is not based on biopsy, with the exception of granulomas, granulomatous inflammation such as TB and sarcoidosis. And the reason behind that is granulomatous prostatitis typically present in a manifestation similar to that of prostate cancer, and we have to rule out malignancy. The most common cause of granulomatous inflammation in the prostate is the installation of BCG in the urinary bladder for treatment of superficial urinary bladder tumors, as we will see later in the lecture. TB is another cause of granulomatous inflammation, although it's rare. Acute bacterial prostatitis presents with severe pain, fever, chills, and dysuria, which means pain upon urination. This could result in sepsis. And upon digital rectal examination, the prostate, which is very inflamed, can be very tender and painful. Chronic bacterial prostatitis, on the other hand, is less severely presenting, and a typical manifestation is recurrent UTI or with periods of no symptoms. Acute and chronic bacterial prostatitis are treated with antibiotics to kill the bacteria. There is no treatment for chronic pelvic pain or chronic non-bacterial prostatitis. Benign prostatic hyperplasia is very common. It is projected to affect 90% of men in their 70s. So it's very common. Again, it affects the central or the transitional zone of the prostate. And it results from benign proliferation of epithelial and stromal cells. This will compress the urethra, resulting in urinary symptoms. The stromal and epithelial cells in BPH, or benign prostatic hyperplasia, are dependent on androgen, and that's why anything that decreases the level of androgen is used in the treatment of benign prostatic hyperplasia. For example, 5-alpha reductase inhibitors such as finasteride. Prostate gland that's affected by benign prostatic hyperplasia usually are enlarged with nodular surface. The urethra is compressed and is slit-like, and there is variable amount of glandular and stromal proliferation. Some patients will have more epithelial proliferation than stromal proliferation, while others will have predominantly stromal proliferation. The glands will be lined by columnar cells, which is different from the normal cuboidal epithelium, and the lumens will have secretions known as corpora amylaceae. This is a gross image of the prostatic glands afflicted by benign prostatic hyperplasia. Notice the nodular surface. Under the microscope, these nodules are, again, variable amounts of epithelium and stroma, and as you can see in the right-hand side image, these cells are columnar epithelium. Clinically, those patients present with urinary symptoms, specifically difficulty in starting the stream of urine, named hesitancy, interruption of the stream before finishing or completing the urination process, urgency, frequency, and nocturia. Nocturia meaning the need to use or to urinate during sleep several times. And since the urinary bladder is not emptied fully due to the obstruction, This results in urine stasis in the bladder, which increases the risk of urinary tract infection. Again, treatment is with 5-alpha reductase inhibitors such as finasteride, and sometimes if that's not successful, surgery, which is transurethral resection of the prostate to release the obstruction of the urethra and treat the urinary symptoms. Prostate cancer is the most common non-cutaneous cancer in men. It affects men in their 50s and 60s and above that, rarely seen in younger generation. It is less fatal than lung cancer, although it is the most common. And the outcome over the years has improved due to screening. And the most important screening assay for prostate cancer is prostatic specific antigen, PSA, which is a blood test. The pathogenesis of prostate cancer is related to four major factors: androgens, heredity, environment, and acquired somatic mutations. Like what we saw in benign prostatic hyperplasia, androgen plays an important role in the development of prostate cancer. Evidence for this include that prostate cancer does not affect men who were castrated before puberty, meaning these men were never exposed to androgen. Also, men with prostate cancer experience regression of their tumors by anti-androgen therapies. So androgens by themselves are very important in the development and sustaining of prostate cancer, and also anti-androgen therapy is important for treatment. The role of heredity is noticeable and cannot be overlooked, and evidence for that is overwhelming. For example, prostate cancer is more common in African Americans than in Scandinavian or Asians. There is an increased risk of first-degree relatives, brothers or fathers or sons of people with prostate cancer have increased risk. The explanation behind that is related to certain chromosomes and genes, including MYC and chromosome 1q, the long arm of chromosome 1. Environmental role is also plays a role in prostate cancer development, and the evidence behind that is that people from low-risk regions such as Scandinavia and Asia, when they immigrate to the West, they have increased risk of prostate cancer, implying the role of environment. Also, low-risk countries that have adopted a Western style of food specifically notice an increase in the risk of prostate cancer. And certain genetic mutations such as TMPRSS2 ETS rearrangement, PI3K, and PTEN, these are also important drivers in the development of prostate cancer. Morphologically, most prostate cancer are well differentiated. They show well-deformed glands, which are smaller than the normal glands. Normally, the prostate gland, similar to the breast, has epithelial cell and basal cells. Normally. In the prostate cancer, we have only epithelial cells and the basal cells are absent. Those glands are crowded and the nuclei have distinctive nucleoli, which is a very important sign in prostate cancer. Normally, you shouldn't see nucleoli in normal prostate glands. The vast majority of cases occur or follow a precursor lesion. This precursor lesion is named high-grade prostatic intraepithelial neoplasia, meaning there are malignant cells, but they are confined to the gland and have not breached the basal lamina yet. This is a histologic image of prostate cancer. Notice how the glands are crowded, they're small, and notice the black dots within the nuclei. These are the nucleoli. These are very important signs of malignancy. The grading of prostate cancer uses the Gleason score. Basically, we have 5 patterns. Grade 1 is the most well differentiated, meaning it is the most similar to normal prostatic glands. And grade 5 is the least differentiated, with no glandular formation and solid sheets of malignancy. We use this score for grading of prostate cancer. Clinically, most cancers are discovered on a patient undergoing biopsy. This biopsy was dictated by elevated PSA, prostate-specific antigen. A minority of these patients will be discovered on tissue sent for benign prostatic hyperplasia. As we mentioned before, people with BPH might undergo surgery, and this surgery, they take chunks of the prostate gland to release the urethra from the obstruction. This tissue will be sent to pathology, and sometimes we discover incidental cancer in these tissues. Cancer typically affects peripheral zone, unlike the BPH, which affects the transitional zone. Tumors can invade locally in the pelvis, and when they metastasize, they go typically to the bone. The bone involvement is osteoblastic, which is opposite to osteolytic, common to other cancers. Prostate cancer is one of the few cancers that causes osteoblastic reaction in the bone. Few words about prostate-specific antigen. It's a serine protease that functions to liquidate the seminal fluid. It's used for screening of prostate cancer. Levels below 4 nanogram per milliliter are considered normal. Above 4 nanogram per milliliter are considered abnormal. The problem with PSA, it's not a very good screening method, although it's the only one we have. One of its problems is not specific for prostate cancer. For example, a patient with any pathology in the prostate, including inflammation, infarcts, or BPH, could have PSA elevation. And unfortunately, some people with cancer have normal levels of PSA. Again, this is the only one we have, but it's not perfect. The significance of PSA really manifests itself in follow-up. So if a patient has prostate cancer and was treated, then we use PSA levels in the serum to detect the progression or the completion of the treatment. So its role in follow-up and screening, although it's more successful in follow-up than in screening. Treatment of prostate cancer depends on the stage. Localized diseases, meaning localized to the prostate gland, are treated with radical prostatectomy and radiotherapy to the pelvis. For low-grade tumors with low PSA in old men, sometimes follow-up is enough because typically low-grade tumors that are confined to the prostate gland do not affect the survival of patients, meaning they do not shorten the time, the expected lifespan of these patients, especially in older men. Tumors with advanced metastasis to the bone are treated with androgen deprivation by either orchiectomy or synthetic agonists of LHRH. A few words about this. Now, LHRH stands for luteinized hormone releasing hormone. And logically, agonist to that, one might think that agonist to LHRH should increase androgen. However, normally LHRH is secreted in pulses in our body. But when we treat patients with agonists of LHRH, these are given constantly. And for some reason, constant release of LHRH results in decrease in androgen, not an increase. And that's why we use them to treat prostate cancer, advanced metastatic disease. The problem with androgen deprivation is that a clone of cells that do not need androgen will evolve and overcome these medications, eventually leading to rapid development and death. A few words about bladder, ureter, and urethral diseases. Remember the urinary tract, which starts from the renal pelvis down to the ureters, to the urinary bladder, and then the urethra. Most of it are lined by transitional epithelium, which is multi-layers of epithelium called the urothelium. Under that, we see the lamina propria and the muscularis. The muscularis in the urinary tract is very strong and thick. We will discuss briefly some congenital anomalies, inflammatory disease, and neoplasms. The ureter is rarely involved by any disorders. Two are worth mentioning. One of them is uretero-pelvic junction obstruction. As you can see in the image, the left hand side is normal and the right hand side is the one affected by uretero-pelvic junction obstruction. There is an obstruction, or rather a narrowing of the lumen between the renal pelvis and the ureter. It's more common in males than in females. It's common during infancy. It's very common in children. And it causes hydronephrosis, which is dilatation of the pelvic calyceal system due to obstruction. Treatment is surgical. Retroperitoneal fibrosis is an inflammatory fibrotic process that involves the retroperitoneum and encases the ureter and results in its narrowing and obstruction. This is caused by IgG4 positive plasma cells, which is part of a family of inflammatory fibrotic disorders that involve the pancreas, the mesentery, and other organs, characterized by severe fibrosis and infiltration by plasma cells that are positive for IgG4. Other causes include medications, irradiation, infection, pre-surgery, and malignancy, and when no cause is found, this is called hormone disease. Let's discuss a few slides regarding non-neoplastic conditions of the urinary bladder. One common condition is diverticula. Diverticula is the plural for diverticulum, which basically is an outbouching of the urinary bladder wall. This could be congenital or acquired. It is most commonly acquired, actually, due to prolonged urethral obstruction, such as what happens in benign prostatic hyperplasia. So, one of the complications of benign prostatic hyperplasia is actually urinary diverticula. The problem with diverticula is that they could retain some urine, and as you probably know, urine stasis is a significant risk for bacterial infection. Cystitis is inflammation of the urinary bladder. It could be bacterial. Bacterial cystitis is more common in females. It is called urinary tract infection, UTI, and typically is caused by coliform bacteria, specifically E. coli. Hemorrhagic cystitis can be caused by either adenovirus or some chemotherapeutic agents, specifically cyclophosphamide. Interstitial cystitis is a cause of chronic pelvic pain in women, which results in significant irritation of the bladder wall, which manifests as increased frequency and urgency and hematuria. This condition increases in severity with bladder filling and decreases mildly upon emptying. Interestingly, half of these patients have remissions spontaneously without treatment, and some might be complicated by fibrosis. Malakoplakia is an uncommon inflammatory process resulting from defects in the phagocytic activity of macrophages. This means that macrophages will engulf the bacteria but will not be able to kill them completely. This accumulation of bacterial debris will be seen as granular debris or granular cytoplasm of the macrophages. And the cytoplasm will also have calcified bodies named Michaelis-Guttman bodies. The arrow points at one of these Michaelis-Guttman bodies, characteristic of malakoplakia. Polypoid cystitis is an inflammatory process caused by chronic irritation, resulting in the formation of papillae that are broad-based. This is benign and does not increase the risk of malignancy. The most common neoplasm of the urinary bladder is urothelial carcinoma. It's more common in men. It affects men between the ages of 50 to 80, rarely before that. Squamous cell carcinoma is a rare tumor to affect the bladder, although it's more common in Egypt due to the prevalence of infection by schistomiasis. Adenocarcinoma is also rare, but it can also affect the urinary bladder. Risk factors for urothelial carcinoma include smoking, occupational hazards such as exposure to dyes and benzene, radiation therapy, and exposure to cyclophosphamide. Cyclophosphamide is the same chemotherapeutic agent that causes hemorrhagic cystitis. Morphologically, there are two precursor lesions, meaning malignant lesions that are not invasive, that do not breach the basal membrane. These include non-invasive papillary urothelial neoplasia and carcinoma in situ, which is flat, not papillary, but also confined to the epithelium without invasion of the lamina propria. These are two images of papillary neoplasia, non-invasive papillary neoplasia. Notice the papillary architecture. Notice the cells are kind of irregular, slightly pleomorphic, with mitosis in the middle of the field. Mitosis should not be seen easily in normal urothelium. This is an image of carcinoma in situ. Notice that there is no papillary architecture. The cells are confined, the malignant cells are confined to the epithelium. Notice the significant pleomorphism and, again, another mitosis in the middle of the field. The prognosis of the non-invasive lesions depends on their grade. Since carcinoma in situ by definition has high-grade cells, without treatment it can progress to invasive malignancy in 50 to 75% of the cases. Once invasion has occurred, stage becomes the most important factor. These are schematic images of various neoplasias. In the left-hand side, notice the papilloma and the flat non-invasive carcinoma in situ. These are the precursor lesions. And the right-hand side shows the invasive lesions, and they both could be either papillary or non-papillary. Clinically, the most common presentation is painless hematuria. Recurrence after treatment is very common, and risk factors for recurrences include the tumor size, meaning the larger the tumor, the higher likely to recur, stage, grade, the higher the grade, the higher likely of recurrence, multifocality, and the presence of concurrent dysplasia or carcinoma in situ. Treatment of urinary bladder depends on the stage and the grade. For example, small papillary localized diseases are treated with resection. More high-risk tumors are treated with immunotherapy, followed by chemotherapy. This includes intravesical installation of BCG. BCG will induce granulomatous inflammation, which will help in killing the tumor cells. And sometimes radical cystectomy is used, but it's reserved for cases in which there is muscle invasion, in which there is carcinoma in situ that does not respond to BCG treatment, or carcinoma in situ that's present in the prostatic urethra or involving the prostatic duct, because these are unlikely to, because BCG is unlikely to reach those areas and result in cure. Thank you so much for listening. Please stay safe, stay healthy, and talk to you later.